And I'll get the recording of this. I scheduled some time right after this to get out the recordings, so I'll pull them together from the last couple and this one, try and push them out right after this course hour I have off. I can't do that.
That would be super great.
So those of you who read the article should at least, at the very least, skim the article. A lot of good material in there. And both articles I selected were from Jill Cook, and she's great. She has some great podcasts and lectures on YouTube that are out there. She's Australian, which is fun because she can be a little cheeky at times. So that's always kind of fun to listen to. Especially as a podcaster, so they ask an off question. She's a little entertaining to hear. But her tendinopathy work and research over the past 20, 30 years, the model holds up pretty well. And she's a good source to have. So when I looked at this going over tendinopathy, I did kind of seek out that she put out. What did she put out lately? Her traditional article on like the three phases of tendinopathy came out, I think, 2009 in British Journal of Sports Medicine. And I referenced that toward the back end of that. That's a nice one just to look at that in model. So for these articles didn't necessarily get into stimulating forces in tendons. What we're going to see is that, kind of, I like to think of the three things. We have tension in tendon, which is kind of what we always think of. We think of tension, what a tendon is designed to do, that linear tension it takes. We think of the eccentric or negative stresses that go on. We get high tensile forces in the tendon. Compression is something that they really look at when they look at, when we get these kind of chronic tendinopathies as being one of the big drivers that can occur. So, looking at like compression in gluteal tendinopathy is a common one, the greater trochanter. You're looking at insertional tendinopathy because the tendon, as it wraps around the insertion point, occur. I think I see this in some of the hamstring tendinosis and tendinopathy that they'll talk about. Is that it's the way the hamstring tendon can be compressed, initial tuberosity in a squat and setup position that occurs, and that concept of I think it's intratendinous compression, where the tendon can become compressed from within, or again externally on another structure that can happen. External compression in the upper extremity, like some of the examples they talked about are external compression. Anything occurs as insertion, wrapped around a bony protuberance or a convex surface. Examples that they mentioned was, the Achilles tendon at the insertion and the glute med tendinopathy. That's always an interesting one because when MRI came around, the diagnosis of bursitis, it dropped a bit because they found that the glute med tendinopathy almost always occurred in cases of the bursitis, have tendinopathy in the absence of bursitis, typically not maybe bursitis in the absence. That Holconism and the bursitis model still persists. There's often a tendinopathy associated with it, but sometimes the bursa can be painful and the tendon may be non-painful. And again, you got compression, the Achilles, they talk about the posterior border of the calcaneus. And again, glute med on the greater trochanter. And those are lower extremities. I think I put lower extremities here. I'll swap it around. Again, lower extremity, upper limbs is long head of the biceps, tendon, and the humeral head and the bicipital groove. We'll talk about that a bit as we get into module covers the shoulder and some of the tests for the pressure along the biceps tendon. Well, Eric, you'll happily show you. Biceps, tendon, radial tuberosity and a distal one. Well, for the extensor carpi radialis brevis tendon, that'd be along the level of the lateral epicondyle. You'll find tendinous irritation occurring there, and supraspinatus tendon along the humeral head and greater tuberosity. So the compression model is nice. I mean, not a lot of people think of that in that model when I really looked at. Internal compression is a good one. And the other article, the bonus article I put in there was one on internal compression. Can be a bit tedious and detailed for those of you like tedium and detail, but got any knocks over the years was the idea that, okay, hey, where is the evidence base or there? But nice to use practical evidence of why we're doing and what is the background of why we're doing it. Those articles are nice to give you in the back of our mind as we select our treatment patterns. I got it. Hey, Patrick, get your voice back, didn't you? Let's hear you, Patrick.
Can you repeat that again, Dave?
I just want to hear your voice just to see if your voice is back.
Oh,
So you sounded
the
pretty
head is
good.
more clear and I can actually talk today.
Yeah, that's pretty good. I mean, I did kind of like the old one, though. It gave you a little swagger.
I'll try and get a nice little punch to the jaw for you before tomorrow.
Perfect.
Be slurring again.
Good. Okay, Patrick. Were you familiar with the concept of internal compression in a tendon?
I can't say that I am.
Yeah, it's kind of interesting because you don't see it much, but a model that's out there that's, I say more recent is like maybe 8 years. And look at internal compression, it occurs in the mid substance of a tendon. And, the idea is that here that we have increased intertendinous pressure and, activates the mechanocyte receptors located in the peritendon and connective tissue. So, before we're thinking about compression like a bone from the outside, here we have compression from within the tendon. And that can be from fluid swelling within the tendon. That can be from you get a area of degenerative change in irregular formation and that nodule within the tendon that forms, which in Bill Cook's work, he talks about that those nodules that form aren't necessarily those pathological areas aren't necessarily the painful area. It's the adjacent fibrils that transfer load around that area that tend to become inflamed and irritable is one of the models. So that this pathological area that we may find in the tendon may not be the pain generator. Surrounding tissues, which are now being stressed, become the pain generators. So that's what we'll start to see is that we get this internal compression of the tendon activates the A delta and C fibers. Now, we can think about this internal compression of, let's say it's fluid, and we have fluid in here because extracellular matrix tendon gets irritated. The extracellular matrix starts to draw in extra fluid through this chemical process of different cells put in there, which is what happens. We see it that can happen after the acute injury. That that pain process is then generated by that swelling effect. I go out, that person, okay, they run 10 miles and they don't normally run 10 miles. Say Achilles tendon starts to take on extra fluid, it's getting inflamed. That fluid in the extracellular matrix then starts to compress these nerve endings and irritate them. It's often why one of the models of the warm-up effect in tendinopathy, if you're thinking of like local effect in the tendon, is that conditioning leads to basically, okay, we're tensioning this tendon in a very controlled manner. Are we now can causing a situation where we can move fluid out of the intertendinous substances, decreasing that intertendinous dynamic pressure in warm-ups? Now we also have the effect of isometrics when we look at tendinopathies as decreasing pain. There's also a more a physiological model for pain reduction with that. But that idea that the low load controlled loading, let's say in warm-ups, in this person who may have an irritable tendon, is this model that, okay, if I decrease the fluid exudate within the tendon, decreases that pressure within the tendon and they have decreased pain. The other model is that, okay, well, as we do this, it's in that pain modulation cycle that by, okay, now I'm putting stress to this tendon. I got these neural fibers within the tendon are now being stimulated at a low level. They now compensate. So there's this neural compensation there where they find that at a cortical level and a midbrain level that, okay, doing warm-ups, doing isometrics modulates pain for upwards of 8 hours in like basketball players with patella tendinopathy. Well, that model is that, okay, how much of this pain may also be cortically driven? But an intertendinous pressure is one of the other models that are out there that may be explained why we see this decrease in pain after the warm-ups with tendinopathy. And yeah, this is also talked about. Think about these people with tendinopathy having morning stiffness. It's an idea that that fluid reabsorption and accumulation that typically recurs at night. And that's, kind of classic carpal tunnel syndrome model. That okay, some of the tissues reabsorb this fluid and the tendon, you get neural compression. But this neural fluid model is also seen and it's also described classically with neural inflammation. That nerves that become inflamed or irritated take on extracellular fluid, and that creates interneural compression. That's seen also with, sciatica. That okay, this pressure can go up. I think it's like 56-fold was in the study. So these pressures can go up considerably as we do it, but that same model that occurs in the nerve can also happen within the tendon. And explain some of why at night we've been at rest, why we get these increased fluid absorption into the tendon, and we wake up and we have tendinous pain. Oh, I deleted my 2 cases. Okay, let's put them in right here. Let's talk about this in respect to if we had a runner and a lifter. So let's say we have a 42 year old male, say, had hip pain. Right Achilles tendon pain. We have a 34-year-old male with right hip pain 2 months prior or 3 months prior, now has right Achilles pain. And we have a 34-year-old female with right extensor tendon pain, a lateral extensor, CrossFit, 2 times 2 months tendon pain. With each of these individuals, we may find that, okay, what is the warm-up effect like in the runner we may have here? Achilles tendon pain. Now, it would also be classifying, and let's say he's had this pain with the right Achilles. We're going to give him this pain, and we're going to say he's had this Achilles pain 2 months. It's going to put him in a kind of a subacute phase. The acute phase rest would probably be the most appropriate thing to get that intertendinous swelling down, get it to reset, and get him to calm down. But now that we've had it for a while, it's going on, he hasn't stopped running on it, we're entering into a different phase of the healing cycle. So let's think about the person warm up. Okay. Okay, Jacob, what would you do with this person who's the 42-year-old male? He's going to kind of continue to run, and he has 3 out of 10 Achilles pain.
Well, if I'm not going to stop him from running because that's how runners work,
Correct.
I'm at least going to teach him a proper warm up and
Mhm.
engage that muscle prior, and
Mhm.
as well as at least educate him on symptom build up. Right. So if he is going to run, how can we do like more of a run walk program so his
Mhm.
symptoms don't continually to just spike to an irritable level of 8, 9, and 10, where he's doing significant damage to the tendon at that point. So also going to teach him a little bit of strengthening on the side.
Mhm.
So days he's not necessarily running, so he can, overload that tendon and allow for greater than his current body weight through the tendon to strengthen it. And going to also teach him some at night, probably some remedies to at least help his pain and decrease the swelling.
Mhm. Okay, good. Anyone else would add anything to that real quick?
Do we address the hip at all? Or look at it as
Yeah,
far as the,
not yet, but you can. Anything? What would you say on the hip?
well, my concern was, is it do they have some sort of abnormalities for either motion or strength in that hip that's causing an adverse effect on the right foot?
Absolutely, that's going to be your driver. Your
Yeah.
primary diagnosis there is Achilles tendinopathy. One of your contributing etiologies will be the hip. That's most likely probably where this person would be. But we're going to keep this case as we go down. So put these in the back of your mind as we see these, because this is what we're going to kind of come into. But early on, I'm going to think about like the patterns, what we're seeing here in research. We have pain modulation and understanding, okay, why that pain may sometimes decrease with warm-ups, sometimes it won't if it's in a more acute phase. Again, other things that kind of occur with the tendon, not just stimulus, highly elevated tendon pathology is, they talk about glutamate and lactate. These are also associated with increased pressures. So, you have these intertendinous communication, and what happens is this is an example of that fluid within the tendon, as it shows in that blue area. You'll see that fluid is going to increase that intertendinous pressure. And as this tendon contracts and it's compressed, that pressure point goes up. So nerve endings get stimulated, tendon gets damaged. It can also what this occurs is the noxious effect because you have decreased transfer of what limited blood supply it has is now further impaired. And again, one other thing that increases tensile force and tendons they talk about is, it's kind of mentioned here, it's shear. That's an idea. If I think of shear, like within tendons, it can be intertendinous if you have, let's say you have a area of tendinopathy and you have some tendinosis in an area of the tendon, that tendon that shears over top of it, that transferring fibers is going to get shear stresses. And if you don't have shear stress, think about this. Like if you hit your brakes in a car, your body's pulled forward, but your pants and your buttocks creates a shear stress as you're held in your chair by that shear force. With the runner, it's that ground reaction force, and that contact of the foot on the ground allows you to propel forward as you push. You're on ice, and the coefficient of friction is relatively zero, so your foot slips right out from under you. So that's a no shear, but your foot has a shear force and contact, keeps your foot slipping, allows you to drive forward. So there is shear that can occur within the tendon, whether it's the tendon over a bony protuberance or it's intratendinous shear that can occur. Now we talk about, what think a little bit about, okay, both these models with the elbow, we have the Achilles, person with the hip etiology. Personal markers, how do we measure, performance, how somebody's getting better with a tendon? Commonly what we do is we think of athletic performance, not really looking at low tissue tolerances. So for that runner, we're really thinking about, okay, if they get back to running, pain-free and doing well, or 1 out of 10 pain, the same to that CrossFitter who's then able to go into, going into their exercise program, without pain. So, their personal metric may be athletic performance, but as the tendon heals, really what we have these two things: one, measuring their performance, and two, what is the tendon's low tolerance to activity? And that may be one of the things that we need to kind of consider is the global, and this is the runner. And then in our treatment program, we have the subcategory of, what is the right amount of the sweet spot of load potentially for this tendon? And why is it that these loading programs appear to work? So, global program, not specific to the structure, and local program will be specific to the structure. Both these individuals, we're going to be thinking and talking about what are we doing globally to decrease the forces or get the appropriate tendon stress through this tendon structure, and then focally, what can we do focally to either relieve the excessive stress that's occurring on the tendon, or get this person in their appropriate level of stress. And again, also my habituation program is, what's my loading program to eventually elevate this tendon capacity? Complicating all this is the fact that pathology does not predict pain or movement alterations. So they looked at, basically in multiple studies, they look at junior basketball players demonstrating a lot of these individuals had patella, tendon pathology when they imaged them on ultrasound, MR. I can't remember the one they did, but what they found is that not all of them had pain. And that lots of times these individuals without pain, their movement patterns and force production and generation, because they're getting no nociceptive signal or avid signal, was essentially the same. And it's how do we then adapt for it? So what occurs in the body to adapt for these, things where now some we're having decreased load maybe put through this. We think globally there's adaptation compensation, at more metabolically active tissues, such as, okay, what's going on with the muscle or central nervous system. So we're adapting these changes. So we get this variability in tendon load, or we get a pathology in a tendon. There's local changes where we can transfer load around that area of dysfunction. Then there's that global change of, hey, my body's sensing that I'm not able to put that tensile load through this tendon the same. I'm going to change or alter my movement strategy to do this. And up above, if you think about the 42-year-old runner, what Chan talked about, really looking at the chicken or the egg here. It's like, okay, my altered hip strategy now potentially created my Achilles tendinopathy, whereas somebody with an Achilles tensioning problem or pathology may also now alter their hip mechanic, to compensate. Does that make sense? Abby, does that make sense?
Huh, sure.
So,
Sorry, there's a lot happening in my clinic right now.
got
I'm
it.
trying to stay engaged. There's just
Keep
a
it,
lot.
Abby,
I
put
I'm
your
trying.
fires out. Stay the best you can, okay? I get it.
I'm trying my best over
I
here.
get it, Abby. So we'll pick on Ryan instead.
Yeah, I think that makes sense. I'm hanging in there.
Yeah. It's that idea that I can have a tendinopathy, and again, it can be there, it could be, and for most people, you're gonna see they're gonna have tendon changes and they're gonna have no symptoms. Other people will be symptomatic. And then as we watch people move, we're trying to always be chicken or the egg. Do I have something going on in this CrossFitter or this runner where they're overloading the Achilles or the extensor tendons due to a movement system impairment? They're not moving well through their hips. Now their elbow is picking up the extra force. So now I have enough of a strain on the system, cause it to be stressed. Or the other potential is, hey, this person just started running, or they just started CrossFit, and this tendon doesn't have the capacity to handle the new load, and now it's being overstressed. So we can see, like these things, these are just subcategories we think of. Okay, was this tendon ill prepared for this stress? Or have I changed something internally that now creates extra stress in the system?
Dave, I think it's also worth it to add like educating your patients on when you're jumping around, because a lot of times they come in with an expectation of, I have foot pain. Why are you even looking at or working on something else? And kind of how you word it, like chicken or the egg, I'll say, who cares what came first? Let's address both and
Mhm.
see how the body reacts. And that's kind of normally how I'll get my initial patient buy-in, so
Mhm.
that they don't feel like I'm not addressing their concerns or sweeping them under the rug, but still looking at both and just kind of making sure there's patient education when you're taking that kind of global view.
Yeah. Oh, absolutely. And it's what I will generally do is I will focus on their area, and then I'll expound later on these other areas. And sometimes I will make sure that what is their primary concern? Their primary concern is going to be that I can't run, and I run with a running group, and that's my social outlet. And now I can't do that. We're at 42, it's like he's going to think, oh, now I crossed 40 and I'm old and broken. Dealing with those things would be the most important thing to kind of keep it a thing. Dealing with the multi-segmental stuff you can add in later on. But yes, definitely, I think it's a really good point to keep that in. Deal with what their problem is and the patient-oriented problem first. And these are the things that are going on in the back of our mind, but it's coming out on the front as this is patient-oriented. And eventually, we're going to work on your hips because it's going to take the load off your Achilles, and we can show that to them with jumping and movement patterns.
Dave, that does make sense. It all just clicked in my head with you saying that.
Yeah. So that's where it is. It's that patient centric. I'm gonna do a bit of that, and probably if I'm back at any of the later ones, I'm gonna put a bit more of that in there. How do I model it around the patient? We're gonna take all this and say, okay, how do we model it around the patient experience? Again, this idea that I like this when the adaptation may occur in the surrounding aligned fibrillar structures rather than the changes in the degenerative area. I think it's really eye-opening if you haven't thought about it in that model. Is that the Joe Cook's model? It's not the degenerative spot that is necessarily the pain generator in these individuals. It is the load transfer of the surrounding tissue. And then what they'll see in these individuals is there is some thickening of those tendon fibrils and the ability to transfer load potentially around that pathological area. And that's those who adapt well. They see that this aligned fibrillar structure, changes, in that structure rather than changes in the degenerative area. Again, this idea too that research can be really confounding as you look at it. That's why it's kind of nice to have this discussion. I know that it's okay to be confounded, you read one thing that counteracts another. Here, there's a lot of studies are saying eccentric training, heavy, slow, resistive training had little effect on the mechanical properties of the tendon. Changes in mechanical properties they think are the likely candidate of why we see this adaptation to the pathology. The current evidence really doesn't state that, hey, I do this heavy load program, you know, I don't necessarily see that the pathological area changes. I change some of the maybe the loading properties, the tissue around it. Is it that basically in that pain science model or that diagram that we looked at the first course in the first hour of I'm able to better modulate the neural system's ability to downregulate the pain through repetitive loading and habituation. That model's not mentioned in this, but it's good to keep it in the back of our mind. We're seeing that, but we're not necessarily seeing this mechanical change. And they saw that too because it's an interesting study. You know, and so they used to atom bomb test back in the let's say the 40s and 50s. There's like a carbon-17, I believe it is, that, and it's in this research or in these studies that was released at that period of time, and it's all in the atmosphere. And believe it or not, they can measure that in our tendons. And what they're able to kind of tell is that, you know, most all of our tendon was laid down by the age of 17. Because what they can do is they can take samples of your tendon throughout your lifespan, and they can carbon date that C17 molecule to get a sense of when it was laid down. And you know, they can see that, hey, look at Abby's tendon. His tendon was laid down, and it was Abby now. Abby's probably 43. So you know, it was laid down. Hey, this was laid down, you know, 26 years ago in Abby's tendon. So they can see that we don't necessarily lay down new tendon in individuals or collagen, let's say, as measured in the carbon-17 data. There's all these other physical elements that go into tendons. It's not necessarily that we're laying down and getting new collagen. That's based on some of the C-bomb studies they've done on tendon, which I just thought that was kind of rather interesting. And in fact, Abby's 40. So she's still dealing with and again, now we just talked about where is the right loading curve. It's kind of what we were talking about before. It's like, okay, we want a loading program for this individual. Say, okay, now we're going to adjust the global movement pattern, you know, and what's going on. The hip's got to move well so that I'm not getting a maladaptive load within the Achilles tendon. You know, so we have that global treatment of that etiology that's contributing. But we also need to then say, what is the ideal loading response that we need in this tendon so that we have a healthy cyclical strain. And this is a curve from the article talking about that maladaptive response. We have that maladaptive response to overstimulation, which is they're finding maybe in that greater than 9% of that cyclic strain, where now all of a sudden, you know, we have these different, you know, chemical expressions and gene expressions that go on. This maladaptive response to overstimulation. You know, there's this adaptive homeostasis, which is going to say, okay, here's where is my sweet spot in loading. Whereas I load the tendon at this 6% of its cyclical strain, I get these normalized or positive responses within the tendon expression. Okay, I have a normal load here. I need to lay down, you know, more type one collagen, RNA expression, you know, collagenase expression. It's moving this stress strain curve further to the right so that this tendon can take more load. And then the maladaptive response to understimulation. So now I have understimulation in the tendon and there's no load through the tendon. So I have a negative response if I have no strain in the tendon. And that's kind of the trade-off when we look at, hey, I'm going to put somebody in a boot for a while and I'm going to not load this tendon. You know, again, yeah, I get the inflammatory portion of it down. I may get that intracellular tendon swelling down because of, you know, now there's less stress through it and I reset it. But the trade-off is going to be with this maladaptive response if it's continuous for a while. Or I get somebody who gets, they have a distal fracture somewhere and it's they have a boot on and they're not loading for 6 or 8 weeks. You know, one of the things I need to consider is this tendon region now not having load. And there will be this, so in that individual, this gradual tending reloading response we want to talk. And again, this idea of this mechanostat point, which I think if you just read this article quickly, is it gets kind of confusing. And that mechanostat point, they're really referring to that green area in this line of we're all different. Where this green area occurs and this loading response is different in individuals. It's different in how we trained. So this positive stress strain curve will be different on different individuals. But if we're looking at treating the tendon, building capacity, and somebody wants to do more, we're looking at moving this stress strain curve further to the right so that this person can take more load and be in that adaptive homeostatic response area. So any of our heavy loading, high resistance, eccentric programming we're doing, what we're really looking to do is to take this stress strain curve and shift it to the right. Michelle, we were talking, what was the tendinopathy did that runner have in the case that we talked about last? I'm drawing a blank on it right now since I'm in the middle of this. Yep.
Which one did we do last week?
Did a 40-year-old man, a little bit overweight for running, return to running.
Oh, he had glute tendinopathy.
Yeah, gluteal tendinopathy. So he was one that had that posterior gluteal tendinopathy. So the first thing we can assume, we learned earlier, it's he had taken time off of running and had come back to it. And he's a bit overweight, so the forces are going to go up in there. And ignoring his running mechanic completely for now, we can think about the stress strain curve and that where, okay, he took time off running. So where his curve may have been further shifted to the right, let's say for the gluteal tendon or any other tendon, he's been on the couch eating Cheetos for the past 2 years. His curve is going to be shifted to the left. So the tendon's ability to take strain is going to be significantly less than what he was used to when he was marathoning before. But like most people, we want to go back to where we were, not where we are. So he starts off and he gets back into training at a higher load level. And now all of a sudden, though his tendon before could take, the strain, what was normally a 6% cyclical strain in him is now a 9% cyclical strain because of his body weight and lack of conditioning. So now he's in that maladaptive overstimulation phase, even though he's doing the same training he was doing. His tendon changed underneath of him, even though he's continuing to do the same training. So now his tendon is overloaded. So this mechano stress points, good to understand that sweet spot in that load once we're triggering. Again, pain associated, with disuse, understanding that, okay, yeah, this is going to have a negative effect on muscle strength and kinetic chain function. You get pain in one of these tissues, your whole cortical map changes. So now all of a sudden you got, let's say in this case, we're talking about this guy with Achilles tendon pain, we're going to go back to cortical map changes, absolutely proven. Transcranial stim, they looked at that, Achilles tendon pain, your brain map changes, and now it's negatively affected kinetic chain function and muscle strength. In the runner's case here, probably what happened is the hip pain changed his cortical map. Now trying to drive from maybe the Achilles and the lower leg more, and it's overloaded and moved his curve into an overload phase because of that. Or if you hadn't run recently, then it could be in the lower phase. That would be most likely the abnormal adaptation of his biomechanics. Running is very hip driven, where gait is more ankle driven. So that 42-year-old runner with hip pain, trying to compensate with an ankle strategy, probably going to overload his Achilles tendon. I hate to say it, Chan is right. I won't. Good. Again, what we're looking for here is, like in all our training programs, is the appropriate loading in the adaptive response phase to create positive change in the mechanostat. We want to move that curve from the maladaptive one to the normal homeostasis, and here we're shifting that curve to the right. So our rehabilitation program, our training program, if we're running or doing CrossFit, we need to kind of move this curve over to the right. The female CrossFitter with lateral extensor tendon pain, we may have a abnormal motor control pattern. Maybe it's coming from her hip, maybe it's her back. She's compensating with the tendon gets overloaded. One, as a PT, is what we need to do is be able to address the global pattern that may be driving it. Finding the biomechanical stressors is what you're going to do this weekend. And then now we're into the loading phase. Okay, I still have a dysfunctional tendon. Chan addressed the hip. He's got those mechanics cleaned up. We're addressing that. But we're still left with a dysfunctional tendon, which, okay, we need to find what is the right adaptation, homeostatic loading program to build capacity. If we're looking at posterior tib tendon, And we got to figure out, okay, if they're in a grade 2 and they start to get mid-foot collapse or overpronation, I need to address that external stressor before I start building capacity. So there's a lot of variables, and Eric's great at this. So I have no question you're going to take these things and run with Eric, but understanding just here's where we are in our rehabilitation process and why we're looking at loading programs where we want to move the curve. Chris, does this curve make sense to you? I see you unmuted. But you got no voice. Now you're muted again, Chris. Give it another try. Go ahead. No microphone. Evan, you're a man of many opinions. What have you got?
Yeah, Dave, it makes sense to me. Short and sweet.
What loading program to use for Achilles tendinopathy?
I've more kind of shifted my opinion away from eccentrics only. Really got into the research of the heavy slow. So I would say I load it with all three.
Okay.
I do concentric, eccentric, as well as isometrics.
Mm-hmm. Yeah, and it seems where the research has kind of trended, hasn't it? It's at first it was okay, eccentric load was it. And then they're like, well, wait a second here, heavy load has some real value. And I think heavy load more recently has shown to be maybe a little bit better than eccentric. And then some people are like, oh, let's hold on now. Maybe concentric has value too. And why we kind of get all over the place with it is because somewhere where we want to be is this adaptive homeostatic model. We want to be what gives us the best chance at the sweet spot. But think of also why maybe the eccentric and some of the heavy load work may work is because we have high tensile stress. If we warm the tendon up, even if it's an intertendinous compression model, that idea of that slow strain or that slow compression is more likely to then, or look at is like moving the fluid out of the tendon. Versus if we go into plyometrics, i.e. running, jumping, then we're rapidly loading and compressing the tendon, which when we do that creates rapid tension within the tendon. But that one doesn't work as well as we do it. It's intertendinous compressive model of increased fluid or, basically a area of fibrosis that's just creating compression. Rapid model doesn't work. So it makes sense that
Dave, that's where my brain went when I started looking at this. Like I was thinking more of a return to running program,
Yeah.
Like slowly loading and intervals and grading load at 10%. So is this only talking about a load like concentric, eccentric, isometric, like Kevin was saying, or can we apply the same model to like plyometric loading?
I have to look at this because you eventually have to get them back to plyometric loading. So, like with this loading model, we're gonna do that to a degree. Idea is that you think about that stretch strain. If I put the strain rapidly into the tendon, depending on this individual, it's how well do they adapt to it. So somebody who's coming, let's say it's the Achilles tendinopathy, a 42-year-old runner. I know that if I take them and I try to make him an immediate 4-foot runner, it's probably going to go really poorly. But over 12 weeks, I could probably make him a runner with a graded loading program and sequential progression. I would probably end up doing is making him a midfoot runner. And the reason why is that with the heel landing and the 4-foot contact at the same time, I'm going to decrease initial vertical ground reaction force, smoothing out the curve, and the Achilles tendon doesn't accept that first initial load. If I increase the hip drive in this individual, and maybe it's a glute and hamstring activation, the early portion of stance, I'm going to decrease the amount of Achilles tendon load that may, or the increase the load rates of the Achilles tendon during that portion of the gait cycle. So yeah, I'm gonna have to get this person back to running. I'm gonna try and modify these loads. So at first, how can I decrease some of the speed of loading of the Achilles tendon is what I want to be able to modify in this individual. If that makes sense, which is that plyometric moment of the Achilles tendon. And I want it working in harmony with the other muscles that are active during its loading phase. Because running is a ballistic motion in that range. Does that make sense?
Yes, thank you.
The other thing, the concept that I chatted about this with a little bit Michelle the other night was that, you know, again, even with the Achilles, we don't often think about it, but if I'm going to unload the Achilles and maybe the gait cycle, we don't often think about it, but the swing speed of the opposite leg coming through will, in essence, decrease some of the Achilles load. I don't have research on it, but it holds true, right? And they can tell the difference is that it's sometimes what happens is the Achilles gets painful. We load that leg a little bit longer because we don't want to generate force through it, but that other leg swinging through gets the body weight coming over the foot faster, and it decreases maybe the load and pull force that the Achilles has to deal with. So that plyometric loading phase, there's many ways we can kind of decrease it. So I'm going to work on the foot strike, where it is in relation to their body, how quickly it's coming through, and even enough swing speed of the leg will decrease some of that loading force and hopefully keep them in that green zone. So now I can train them this more adaptive homeostatic region versus my foot hits the ground and I wonk through it and then I over dorsiflex because I didn't want to fire the calf muscle because my Achilles hurts. Now I over dorsiflex and I compress the distal tendon into the calcaneus. So it can feed into it. So to some degree, I think plyometrics are valuable. We need to get back to them to get into load transfer. What Ebony Rio did in her study where she looked at that 8-phase Achilles rehab in dancers is that rather than doing the plyometric footwork on stairs to whatever the dance beat that was very common for warm-ups for the Australian dance troupe, because they needed to load the Achilles at a certain tempo to be able to go back to dance. That's a cortically driven model that, okay, we need to be able to kind of load that Achilles. So plyometrics needs to be a part of that return to sport, just a matter of when we introduce it. And if he's a 42-year-old runner who's not going to stop running in the presence of this, then I'm definitely going to play with how do I modify that plyometric load with foot strike, pull through, and even if I have to, I can get into swing speed. And that's what it is, that idea that changes in the tendon may contribute to, but enough will explain improved athletic performance, i.e. the tendon may not have changed, but their athletic performance and their pain may have gone down. Musculature and nervous system and other connective tissues that contribute to that personal, level adaptation. So that idea that that person is into pathology, multiple factors kind of go in. Put in some of the data on collagen synthesis, and this may not be as germane to where we are now, that you're going to see changes and markers in these tendons immediately after exercise. And you can think about that in a sense that we see collagen synthesis markers 24 hours post exercise. It's the stacking of workouts which can be problematic for some people. That idea that, okay, I did a long run yesterday, last night, and I'm going to come back and I'm going to do a hard plyometric workout in the morning. That the tendons you'll see, and they even see this, the same research holds true in disc. You see disc changes and fluid content changes every coverage over 24 hours. And there can be a summation effect. I've seen it in triathletes over the years where they stack too many high distance or intense workouts too close to each other, because now all of a sudden you have this common increase in collagen degradation markers and enzymes that are detected within that 24-hour to 72-hour period. They don't recover enough, they come back and hit it again. Now you get this increased degradation of these markers again. So spacing and timing of these workouts then becomes kind of really important. I'd go to, if they're younger in their 30s and 20s, like a 36-hour pacing. If they want to do 2 days in a row that are like higher loading workouts, I'd at least try sometimes to almost space it out by 36 hours. So morning on a Monday, afternoon on a Tuesday. And I think what happens is you're seeing that in the collagen, the muscle recovery, that some of these markers that recover for 24 hours, that extra 12 hours really helps out. They're really hardcore about it and they're training for something specific. And the timing based on just these synthesis markers that you'll see post exercise, it's being aware that kind of helps. And this is why we're going to space out these workouts, because there is increased fluid and there's increased, digestive enzymes within these structures in that first 24 hours or so. So if we space it out a little bit, your tendon gets a chance to recover to a baseline where we apply that stress load again. If you think about it, it's the model they use it when they kind of, those of you who've done instrument assisted soft tissue mobilization. This is exactly kind of what they talk about, that, hey, you're gonna do the A-stim or Graston technique on a Monday, you're gonna give them to a Thursday or a Friday, you do it again. Has anyone heard anything different, or is that how you're taught this? Who here does any kind of instrument assisted work? Volunteer yourself up. Before I pick on Ariel. Stephanie, you doing any soft tissue assisted Graston, A-stim?
Yes, I do Graston, and that's what they kind of taught us in the course as well.
Yeah.
To have that kind of period in between the sessions that you would do.
Yeah. And it's kind of that idea that you're trying to traumatize the tendon. So you're almost in some ways, in more of a positive way they're thinking about it, it's traumatizing that tendon now. They still teach it as being a mechanical effect in Graston, or they talk more again about the tissue, the fibroblast formation growth factor bruising effect that happens.
Yeah, a little bit. I had a truncated version of it, so we didn't go as in depth about like kind of the underlying properties of it. But I believe I only have the M1 in for Graston. I think M2 they might do a little bit more of the mechanical, or kind of like I think they do movement with Graston in the M2. But I have not taken that one yet, so it might go a little bit more in depth on that one.
Yeah, but that is essentially kind of what they're looking at now, is more the tissue. It's not so much you're breaking up fibrotic tissue, it's that you're stimulating basically this process of controlled bruising and tissue and tissue, whether it's remodeling in that standpoint, or you're trying to kind of jumpstart that occurs with tendon strain and tendon load. I think there's multiple things which work in that same element, whether you're looking at shock wave, to some degree, low level laser, maybe. There's other things that do that. In my notes here, that's where I mentioned earlier, the integration of new collagen. We talked about, just to jump here a little bit, and it appears limited after skeletal development. They really talk about age 17 is what they. I thought that was an interesting fact too, that the collagen rate in the horses 0.25% a year, which gives it a half-life, meaning that you'll turn over half of your collagen in 200 years. If that model holds true to us, which probably does. So you can turn over half your collagen in the short period of time of 200 years. So this idea of, being able to redevelop the collagen, and lay down, a new one it's a bit strange now. Types of collagen change. We don't necessarily get a new one. And that's that idea of it. Oh, I did reference it. It's carbon 14, where you kind of look at relative age of the tendon, because they can see that they can measure this, and that most of the C14 levels were laid down at you were 17. Thought was increased, that the increased tendon dimensions in response to exercise have consistently been observed in younger patients. That, now loading our tendon at younger ages, does it have significant value for later in life? That loading in those younger periods and getting that stimulus, does doing the exercise and having this load, give you more capacity? They don't know. There's not been that longitudinal study done per se. But would it be optimal to be more active when you're younger, to have more tendon capacity? The only thing I think, this is pure opinion, is that you see some of this. I think the people who are some of the more successful 4-foot runners are the ones who ran in high school and college. And it's more thing, I think, is because they've been having that adaptive change in the tendon system in the body, in those formative years, so that their collagen strength in the system may be reflected in that. I don't think it's solely it, but it is an interesting concept to think about. That those people who may have been more active in that period, maybe those people that more naturally adopted. Those people adopted later because of ground reaction force issues and others. They're the ones who may have to balance the Achilles tendinopathy, hamstring tendinopathies, because their body did not adapt maybe in the formative years because they weren't playing soccer or other loading sports. Again, about that critical window. And again, it's important to state here that the absence of change in tendon and cross-sectional area over life not reflect the absence of tissue-based adaptation. There's going to be tissue-based adaptation. Tendon adopts a different mechanism that post-skeletal could be cellular matrix, other things that they're looking at, as being properties, not just the cross-sectional area of the tendon. That's an idea here. So let's say in case 1 and case 2, are we changing in the Achilles tendon case and the elbow tendinopathy? Are we really changing? What are we changing in these individuals? And again, here they're saying is that numerous studies suggest that these transient changes, there's these transient changes that occur in tendons. And that idea that, okay, with that runner in that CrossFitter, what we need to do is we need to find their optimal sweet spot in loading. Because in this case, we are going to get different things. We're going to get tendon tissue creep, and there's changes immediately after work on the vasoelastic properties of the tendon. So a tendon may have a little bit more length. So that runner, I think what we may see is that we're thinking about tissue creep. Oftentimes, is anyone here seen Achilles tendinopathy and noted that sometimes these individuals aren't always necessarily tight, that they tend to sometimes have excessive range of.
Yeah, right now I actually have a gentleman with kind of bilateral Achilles tendinopathy, and he's got 12 to 15 degrees of dorsiflexion.
Yeah. So what you're seeing here is what the bullet point too is excessive tissue creep that occurs. That weakening of that matrix, again, allows that tendon to creep, and it's going to have influences. Like he may actually be weak at the whole plantar flexion, like a 1 foot, because he can't generate proper length tension relationship within the tendon muscular structure. And oftentimes you'll find these people here that get breakdown of the system and lengthening. Now he'll also be prone to that compressive model because he has excessive dorsiflexion now. Basically the tendon and the deep fibers of the tendon in particular tend to become then compressed against the calcaneus. And that's that compressive model that occurs. But it's often that I'll find sometimes these people, it's not like, oh, I need to stretch out. They want to stretch because that stretching and elongation has that pain modulatory effect temporarily. But, the problem is not that they need to be stretched. It's the fact that this thing is probably excessively, you have some tissue creep going on here over lengthening. That breakdown then can contribute to either the compressive tendinopathy or that mid-substance, there's fibers that have to move around that pathological area, can't transfer sufficient load because they don't have the proper stiffness. And they'll address the idea of stiffness in this article. And it's debated whether stiffness as being the thing you need to improve your condition, or is it less stiffness? It's somewhat up for debate, role of stiffness. Idea where, okay, if I have a tendon, where's the optimal loading properties? Where a tendon is too soft or too stiff, may put this tendon at risk for injury. That really clears things up to know that, hey, it's kind of the Goldilocks thing. I could have a bed that's too soft or a bed that's too firm, and I'm not going to be comfortable. With tendons, is this tendon too soft? And sometimes is this tendon too stiff? So don't think of this as being confusing. Think of it as being liberating. And that, take the patient that you see and kind of be ready to accept what they give you. This person may be, they may have a lot of stiffness. So we may want to then approach, okay, a graded adaptation, lengthening under load to improve strength through range of motion may benefit that person. The individual that Patrick saw has excessive length, but we need to control that length and that dorsiflexion. So that movement pattern control, because if they load every time they run and they drop rapidly into dorsiflexion, they're going to be loading the Achilles tendon. They need to kind of neutralize their position. Like they may do well with a Hoka or some heel elevation in their shoe. With the elevated heel versus something stiff, maybe a flatter shoe or adaptation maker. So again, it's unclear whether stiff tendons or less stiff tendons are desirable in endurance athletes, because just keep that open mind, that take what comes your way and assess them for who they are. You may have an expectation that it's stiff or loose. When you don't find it, work on the model that makes sense. and address what you think may be the stressor. In some cases, you have to kind of flip your model. Again, rehabbing tendon specifically, global models are helpful to change movement patterns. But if we're looking at moving that tendon stretch strain curve, that targeted musculotendinous unit interventions tend to have the greatest effect on the mechanical properties, mechanical loading of the tendon. So a global system approach may work for some, but really to get those adaptive changes in the tendon, you need a specific tendon loading, aponeurotic tendon mechanical loading program to really create those changes. And that, they look at these, what do you think? So if we're doing plyometric training, running, since it is such a multi-joint functional system, we may not be getting adequate load to build capacity within a specific muscular tendinous unit. And that's the argument for specific loading programs for the tendon as being a component in the rehabilitation program, as well as looking at the whole person and the whole movement pattern. Because that's going to be your long view. I need to create capacity. That is your 12-week program. Make acute changes by treating the entire system and moving stress strains around. Got to be more of an immediate adaptation effect. Skip over some things here because we are out of time. Again, real quick here, you have my notes. I'm going to go over local effects, decrease compression when we can, decrease dorsiflexion, release loading. Patrick's patient. Heavy, slow resistance, also give better results, than high speed exercises. The reasons we talked about, heavy, slow resistance gives the tendon time to react. Doesn't increase the intertendinous pressure or the tensile forces rapidly. So early progressions, slow resistance, better result than high speed exercises initially. And that's because of the associated lower intertendinous dynamic pressures that occur with slow, heavy resistance versus dynamic plyometrics. What's out there too is interesting is, drug treatments, directly targeting elevated gag chemicals, which pull fluid into the tendon. So they're looking at this hyaluronase, the same kind of hyaluronic acid, a form of it they use that we've seen in knee injection, joint injection. They find that basically what this does is decreasing these other chemicals stew. It takes the intracellular fluid levels and can balance back to what is pre-injury levels, so we aren't retaining as much fluid, and we get less compression. That's the compression. Woo. I hope that wasn't terribly painful for everyone.